Welcome to the Council of State Governments webinar series from our headquarters in Lexington, Kentucky. Today we will discuss preparing states for Diabetes Action Plan legislation. I am Marina Bird, Graduate Health Policy Fellow and CSG's host. Let's go over a few housekeeping details. You will be in listen-only mode for the duration of the webinar. You can type in questions in the Go To meeting box on your screen at any time, and we will get to as many questions as we have time for at the conclusion of the webinar. The webinar audio and the slides will be posted on CSG's Knowledge Center, and as an attendee, you will get notice of the link for the audio and slides. Our speakers today are Marti Macchi and Dr. Connie White. They will familiarize us with the Diabetes Action Plan legislation and states' implementation and goals of the legislation. Marti Macchi is a Senior Consultant for Diabetes with the National Association of Chronic Disease Directors. She oversees all diabetes-related projects and initiatives. Her career experience has focused on disease prevention, health promotion, and community wellness initiatives in both the clinical and community settings. She holds a Master's of Education in Exercise Science from Wichita State University and a Master's of Public Health from the University of North Carolina, Chapel Hill. Dr. Connie White practiced as an OB/GYN physician in Frankfort, Kentucky for over 20 years. She is currently the Deputy Commissioner for Clinical Affairs in the Kentucky Department for Public Health, overseeing all the clinical services provided by the department throughout the state. She is also the Director of the Division of the Prevention and Quality Improvement, which oversees all chronic disease programs such as diabetes and the state provider shortage areas. Marti, I will turn it over to you.
Great, thanks. Thanks, Marina. Can you guys hear me okay? Sounds like you can, so I'm not hearing any objections. So it's great to be with you all this afternoon to discuss the Diabetes Action Plan legislation. I've had the privilege to work with colleagues as this legislation has been introduced and passed in several states this particular year, and I'm excited to present this experience of Kentucky as well as my experience in helping states as they move through this process. So we hope that this will be an informative time for you, but we also hope that we can answer any questions that you may have related to this legislation. Next slide, please. So I am the Senior Consultant for Diabetes with the National Association of Chronic Disease Directors, as Marina had introduced me. Essentially, just by way of background, NACDD, which is the acronym for the association, is a national public health association that really does function as a professional organization for public health practitioners at the state level working in chronic disease prevention and control. Our core purpose is to advance the capacity of states and to prevent and control chronic diseases through public health strategies, policy being one of them. We've been around for quite some time, founded in 1988, and we have office headquartered in Atlanta, Georgia, where we've got professional staff that support about 25 national subject matter experts. And we are made up of members across the states that do work in chronic disease prevention and control, diabetes being just one of those. Next slide, please. So today what I've been asked to talk about is essentially the actual legislation. So the way that I have laid this out is just as by very, very brief way of illustrating the problem, talking about the diabetes crisis. I would assume that the majority of those attending this webinar are very familiar with the problem of diabetes and the potential that we are, or what we will be facing going forward. I want to present to you the components of the current Diabetes Action Plan legislation as it is being introduced and passed across the country. I'd also like to give you the current landscape of that, which states have been involved, where they are in the process. And then I'd like to set the stage for the Kentucky team and where they will talk about their experience, but really some high-level discussion about using these plans to guide states' actions that are aimed at people with and at risk for diabetes. And essentially we'll talk about some of the elements that are part of these plans and how they can drive policy change under detection, prevention, and treatment, what those policy levers are, and then the expectations and the potential possibilities of using this plan going forward. Next slide. So we do have a problem. It's a big problem, and it is becoming a bigger and bigger problem every year, as many of you are familiar with the data. If you can go to the next slide, you'll see I love this picture, and many of you have seen this. If you've seen CDC present a lot about diabetes, this is really a good illustrative that does depict what we currently know and what we know is coming, or what we predict is coming. Essentially, nearly 26 million Americans have diabetes, and what many people don't know about that number is that 7 million of that number are undiagnosed. That group is really walking around with diabetes, with no diagnosis, not much of an understanding that they have the disease whatsoever. So we have over 18 million who are diagnosed. What we also know is that in addition to that number, there is an estimated 79 million of U.S. adults that have a pre-diabetes, which is not borderline, which historically a lot of those of us know have diabetes has been talked about when people aren't quite there yet, but it really is a condition in which blood sugar levels are higher than normal, not high enough to be diagnosed as diabetes. And this is a real urgent time for people to intervene in their lifestyle and perhaps their healthcare provider intervention to really focus on the things that can be done to prevent type 2 diabetes. We know that prediabetes raises a person's risk of type 2 diabetes, heart disease, and stroke. So when we talk about these policy levers and we talk about this particular legislation, I do want to raise the sort of the awareness of the continuum of the disease, and that prediabetes is an important time to act in order to prevent diabetes. Next slide, please. Very briefly, we know that by 2050, 1 in 3 adults will have diabetes, and essentially that's due to a variety of things. We know Americans are living longer. We know that even just Americans are living longer. We know that people with diabetes are also living longer. We know that there are increases in minority groups at high risk for type 2 diabetes, which will increase the rates of diabetes, and also the new cases that will be coming on as people are developing the disease. We know that currently about 1 in 10 U.S. adults have diabetes. Next slide, please. We also know that like I said before, there's a significant risk for those for diabetes, and those would be people who are obese, and we know that about 2/3 of all populations are overweight or obese, putting them at risk. We also know, as I said before, that there are 79 million, or 1 in 3, or 35% of adults who have pre-diabetes who are at risk for type 2 diabetes. And what we're finding is that generally less than 10% are aware. It's essentially right around 7% of those that know it. But people who are at risk do not understand that they are at risk, do not know that if they do make some changes in their lifestyle, that they can prevent type 2 diabetes. Next slide. Very brief overview about the facts of diabetes and the personal and financial costs. We know that the number of Americans with diabetes has more than tripled in the past 2 decades. That's just unacceptable that we have a disease that's growing so exponentially. We also know that medical costs for people with diabetes are higher than for people without. These numbers are actually increased with some new reports that have come out recently that show a higher cost, but nonetheless, these are significant costs. We also know that diabetes is the leading cause of kidney failure, non-traumatic amputations, and new cases of blindness. Particularly, it is a disease that has some major complications that have very high costs associated with treatment and management. What we also know is that we have evidence of things that do work. Things that can decrease costs, that can curtail costs, that can improve the decrease of complications. We know that we can prevent diabetes in those who have prediabetes, and that we know that if we do that nationwide and implement diabetes prevention programs, we can save a lot of money to the U.S. healthcare system, and about 885,000 cases of type 2 diabetes within 25 years. So we do have something in our tool belt to be able to address the epidemic. Next slide, please. I'm going to come back around to the iceberg example, and just by way of looking at the illustration, that if you look at the top of that iceberg, we essentially know that there are people with diabetes. We're treating people with diabetes with complications. They belong above the water. People with diagnosed diabetes, we're managing them. They belong above the water. What the last three bullets on this slide illustrate are the people that are below the water, and those that who have undiagnosed diabetes, people with pre-diabetes, and people at risk for diabetes. And I only show you this and I want you to think about this just as it relates to a sense of urgency that policy change aimed at people with and at risk for diabetes is very, very important, and it's actually becoming an urgent matter, one that should be prioritized. Next slide. So what I've been asked to talk to you about today, and what I'd like to illustrate is the Diabetes Action Plan legislation, also known as DAP legislation. So you'll hear me refer to it as DAP as well. And this is a real model. It's a legislation, and when I say model legislation, it's a legislation if it's in a format that includes all of these things. Really, together, the elements of this legislation can include a variety of policy recommendations that can span across the entire continuum. This legislation has been introduced and passed quite extensively this year, and I'll get to that in just a moment. But I really just wanted to give you the high-level overview of the elements of this legislation as it relates to diabetes policy. And essentially, this is legislation that aims to establish a collaborative process across state agencies. And the three state agencies that you will see written into this legislation are agencies that house the Medicaid program at the state level, departments of health, state departments of health, primarily the diabetes program staff that are in place due to CDC funding that would support the staffing for diabetes-specific strategies. And then the third agency is that agency that would be responsible for state employee health benefits. And really what the law requires is that these agencies come together and develop a collaborative plan of action. And this really is a biannual report that provides a very narrowly focused look, highlighting the problems and the costs associated with diabetes. These organizations are asked to use their existing data that they collect, and it does foster collaboration among the state agencies to make very specific policy recommendations aimed at people with and at risk for diabetes that are actionable items for the state legislature to consider. The report is required to include essentially three parts. The first part being the data from each organization, the existing data that illustrates the costs and the impact of diabetes. So each organization brings their data to this report, and that section really does illustrate the problem of the burden and draws attention to the costs associated with the burden of diabetes. The second component to the plan really covers the current efforts that each agency is involved in to address diabetes. And then the third section of the report provides an opportunity for the agencies to collectively provide evidence-based recommendations for legislative action. And those recommendations should include a blueprint for cost and no-cost strategies so that the legislature has the information they have related to the actionable items that they would want to put in action from this plan. And I just want to point out that my organization, NACDD, is committed to this process by providing technical assistance to states as they work to implement this legislation. So as you can imagine, if state agencies have not collaborated or put their data collectively into one report, sometimes an outside consultant can help with that. So part of our commitment is to provide the technical assistance and the facilitation, perhaps, and some of the connections to the evidence-based recommendations that states would like to put into the report. We provide a lot of that. Next slide, please. So currently, the DAP legislation landscape really involves quite a number of states. This slide illustrates legislation that was passed and signed into law by the governors of these states in 2013. And those include North Dakota, Louisiana, North Carolina, Oregon, Washington, New Jersey, and Illinois. Some of these states have a little bit different version of the legislation, but for the most part, the elements of what I just presented in the previous slide around the components of the DAP legislation are included in these laws. So this started for those 7 states. That started in January, and here we are in mid-August, and they are now facing implementation of this law. States who have implemented this law already are Kentucky and Texas, and their DAP was passed in 2011, as you can see there, and I look forward to and I'm excited to hear Kentucky's presentation about how they implemented this legislation. 2 states that have experienced or have some DAP activity are Michigan and Hawaii, where DAP was introduced but not passed. So this is the landscape of the current DAP legislation as of today. Next slide, please. So I'll take the next 5 minutes or so to go over some of the elements that have been up for discussion and have been, and for the most part, for those states that actually have developed a report, have been included in their report. You'll hear more about the Kentucky report in just a moment. But really just considering how these plans can guide policy change, putting actionable recommendations in front of state legislators to really guide policy that can improve the quality of life, decrease costs for people with and at risk for diabetes is really the goal of this plan. So the next slide. So the plan really, like I said before, does allow these agencies to present data on a real kind of comprehensive continuum, if you will. And there are 3 components that really, there are policy recommendations that could fit under each that would be very helpful for the legislature to know. So those are detection, prevention, and treatment. And treatment being those policies that would help to control costs associated with the disease and prevent complications. So the next slide. So under the detection component, very high level, what we really need to know based on the data that we have already available to us is that there are folks out there, there are people out there that have undiagnosed diabetes, and there are people out there that are at high risk for type 2 diabetes that don't know that. So detection is really key, and screening is the entry point to containing the diabetes epidemic. So just a few examples of what you might see in a report such as this include screening state employees to prevent and detect diabetes, engaging physicians to screen to detect diabetes and prediabetes and refer to appropriate treatment, and then very importantly, screening for gestational diabetes in the Medicaid and state employee population at the end of the 2nd trimester and measure for the frequency of that testing. We know that women who've had gestational diabetes have a 35 to 60% chance of developing diabetes in the next 10 to 20 years, and they are at high risk of type 2 diabetes. So better understanding the populations covered by these agencies will allow them to be referred to the treatment options that are best for them. Next slide. Just a quick visual on this slide is that screening is the entry point to prevention, whether you're preventing complications or you're preventing type 2 diabetes. As I said before, we have a large population who are at risk, and we need to find those folks that are at risk and those folks that are undiagnosed. So once they are screened, then we can refer them to the appropriate intervention. Next slide. I did want to just make mention very quickly about the intervention related to those at risk for type 2 diabetes, and there is a large national effort currently underway to stand up evidence-based programs, lifestyle change programs that have proven to reduce the risk of type 2 diabetes by 58%, which is a significant amount, and we see a reduction in those over 60, even higher. But we know that this intervention that can be delivered in community-based settings can decrease type 2 diabetes, and if people are made aware of their risk, having access to those programs is vital for them. So we know what works. The evidence is there. We've translated it into community settings, and having access and coverage for those programs for people to prevent or delay type 2 diabetes is very, very is a very good policy recommendation. Next slide. The next slide essentially just shows the benefits of the diabetes prevention program. It does prevent new cases of type 2 diabetes. It prevents missed work days. It avoids the need for specific medications. We know that it adds quality of life years, and that we know it does avoid a large amount of money in healthcare costs. So it's a very important intervention that can be administered at the community level and paid for by those who can cover it. Next slide. So the recommendation under prevention then would be to cover the National Diabetes Prevention Program for state employees who are at risk for type 2 diabetes as a health benefit, and then in turn doing the same for those who are covered under the Medicaid program in order to prevent type 2 diabetes in those two populations. Next slide, please. The next category of policy levers falls under the treatment and management component, and that really, there are a lot of things that I have available to you in a couple of slides here, categories of policy levers. However, when you think about treatment and management, we can't ignore that coordination of data and information related to the treatment of diabetes is really vital to understanding the true reach and scope of the disease, and better coordination of data amongst these organizations or these agencies is something that can help to draw more spotlight on the problem in order to determine the solutions. And then upon that reform of data collection and data coordination, going forward and developing a plan of action for recommending evidence practices to improve on those results. Next slide, please. Some of those policy levers can be at the health system level as well as at the legislative level. This slide does illustrate some policy-related strategies that addresses improving quality of care, and quite a bit of the policy lever does fall under reimbursement strategies that would allow for value-based benefit design, physician reimbursement incentives and performance-based payment, public insurance reimbursement of medications and testing supplies, patient insurance co-payment change. We know that team-based care is another evidence-based strategy to better manage those with the disease. And so when we think about treatment and management, we talk about improved quality of care. The next slide illustrates that when we have some policies at hand that can actually increase access to sustainable self-management education and support services for people with diabetes. Again, falling in the treatment and management category, having access to programs that are sustainable, that have recognition for self-management education, that are reimbursed, engaging community health workers and other allied professionals in the role of team-based care and providing reimbursement for those folks to be able to help in the cause of management of the disease. And then implementing policies to meet management and care for needs of students with diabetes in schools, so that professionals in schools can also be a part of the team that can help to manage the disease. So those subsequent slides really do illustrate just a few categories, and I think the Kentucky team will give you a little bit more idea of how that's been played out and recommended to their legislature, and how they're actually operationalizing some of those categories. So the next slide, the last slide that I have then is really talking about the expectations and possibilities of such report. And really what this does provide is a narrowly focused call to action aimed at people with and at risk for diabetes. So prevention of type 2 diabetes and all the data that's related to that would really is the focus of this kind of call to action. It will obviously, just by the very nature of providing costs associated with the burden in the state, provide a spotlight on the burden and the costs, more so than it might in any other kind of report. So it's all in one report with these three agencies putting their data into this report. It will allow for evidence-based recommendations by the agencies. And it will increase collaboration among the state agencies, so perhaps reduction of duplication of services or duplication of any kind of actions could be addressed. The possibilities, I think the drafters of this bill would love to see this result in a reduction in the burden and impact of diabetes, essentially also the costs going down, and that improved prevention and management of those with and at risk for diabetes would be realized. So in that context, I think what I'd like to do is turn it over to Dr. White and Teresa and have them talk about how the Kentucky team has experienced this legislation. I'll be happy to answer questions when it's opened up for Q&A.
Thank you, Marty. This is Dr. Connie White from Frankfort, Kentucky, and Teresa Wren. We will be presenting now about our experience, and I'll let Teresa introduce herself in just a few minutes. We're calling our presentation the Kentucky Diabetes Report, the Kentucky Experience. And just to paint you a little picture of Kentucky and why this is so very important, and we have so many passionate people interested in working on this, is the incidence of diabetes in Kentucky has tripled since 1995. We've gone from 3.5% of the population to 10% of the population in the statewide having diabetes. When we look at our the data from our state health workers and our health policy, health plan, we have 10% of our state workers, which reflects the population. In our Medicaid population, 18% of our Medicaid patients have diabetes, and there are some counties in eastern Kentucky where greater than 20% of the population has diabetes. Besides the terrible financial burden that is to the state, the burden to the patient and the families are tremendous. And so we were very interested in this legislation and to try to put a spotlight on, as Marty said, to put the spotlight on diabetes in Kentucky. Next slide. So we're doing, I'm sorry, right there at the outline. So now we're going to just go over for you today. We're going to introduce this a little bit. We're going to give you our background on the legislation, how it came to be, are the partners that were involved, which is just a crucial. Partnership building is so huge. If we don't get that done, nothing happens after that. The process of how these partners got together, the results, and where we are right now after having submitted this in January of 2013, and our lessons learned. Next slide. So I'm going to turn this over to Teresa Wren. I came to my position in December of 2012, so I was not there at the beginning, but Teresa was. So Teresa, if you'll introduce yourself and talk to us about the background.
Well, good afternoon, everybody. As Dr. White mentioned, my name is Teresa Wren. I'm a nurse and certified diabetes educator, and I manage the Diabetes Prevention and Control Program here in Kentucky. And so I'm going to tell you a little bit about our experience with how this legislation came to be here. As Marty mentioned, it was passed in June of 2011. We became aware of the legislation actually after the bill had been filed and it came across my desk for review. And at that time, we really knew nothing about it at all, so we were a little bit shocked, actually. We looked at the legislation and discussed it, talked to a number of people out there in the state trying to determine a little bit more information about it, and really weren't able to find out too much early on. So it was a little bit disconcerting, actually. But we did accomplish our review, and one of the things that we had some concern about was the huge amount of data collection that the legislation asked for. A lot of data, but a lot of data that we didn't really have access to, that didn't really exist yet, and that we would have to really do some intensive work and probably utilize some people that had skills we didn't have to be able to obtain that data. So that was a bit of a concern early on. So there was some information in our review that went back to the legislature that was a issue of concern, and because of that, the legislation was actually amended, and it actually addressed that concern and required only that we had to utilize existing data. So as that legislation has gone forward, as Marty mentioned, that's kind of been part of the legislation that has been filed elsewhere, as I understand it. The legislation did require us to do a report to the legislature in January of each odd-numbered year, so the first one that we had to file was in January of 2013. And next slide, please. And so we took a look at this legislation and tried to determine our course of action. We had some early concerns and questions. We were early out of the gate with this legislation here in Kentucky, so there wasn't anyone else to ask really about their experience. So we were sort of struggling a little bit, wondering kind of where the legislation came from and what did it really mean? Was there going to be duplication of this effort with other planning kinds of efforts that we had done or were in progress at the time that this came about? We noticed that the legislation very clearly said what partners would be at the table for this report, this plan, and it was the state agencies that we've mentioned, but it really not the classic kind of diabetes folks that you might expect if you were writing a diabetes plan. So that was, we were scratching our heads a little bit and looking at all of the requirements of the legislation and thinking, oh wow, this is going to be a challenge. But we did include here for you in the next slide, you'll see a copy of, or a few notes of the legislation, and Marty kind of covered the basic components of that. I will let you read that for yourself if you would care to. But it really was a little bit difficult to discern. I was thinking as Marty was speaking, I would really have been very glad if we had had that nice little concise slide that she had that outlined it for us. But we had to kind of work through that a little bit. And so next slide. We did were clear, certainly in the legislation, that there were required participants that needed to be involved, and that was the Department for Public Health, our Office of Health Policy, the Department of Medicaid Services, and our Personnel Cabinet, which includes the Kentucky Employees Health Plan that provides our insurance for our state employees. Now, Kentucky's really fortunate that public health and the Office of Health Policy and Medicaid are all in the same cabinet here. So that was a little bit easier to deal with. I know that's not true in all states, but that was helpful. We chose also later on in the process of implementing this to add a representative from NACDD, which happened to be Marty. And we were really glad to do that. That didn't happen until August of 2012, but as we were trying to discern more about the legislation and how we needed to proceed, it was very helpful to have that more national perspective and larger picture that Marty could provide for us. So that was very helpful. And I'm going to turn it back to Dr. White to talk about process.
When this law was passed, the Cabinet Secretary, the Secretary for the Cabinet of Health and Family Services, where we are housed, we were assigned by the Secretary to be the lead agency. So as I like to say, we were the party planners. We brought everybody to the table. We asked them to bring their data with them, and during the meetings that ensued for the rest of that year and a half, it was let's take all of these things and see what we can learn. Again, putting that spotlight on diabetes. So the program manager, diabetes program manager, who was Teresa, was asked to coordinate the effort. She was the chief party planner. And representatives were selected from each of these different agencies, and meetings began June of 2011. There was a lot of time, as she said, at the beginning of all the meetings of trying to exactly decide what we wanted to do and what the report needed to look like, especially from the data section, because lots of people had lots of data, but how do you take that data beyond numbers and actually turn that into a thought process that can be helpful and move the state forward? Next slide, please. So what we were determined that the report would have data about diabetes in Kentucky, what each agency is currently doing, as Marty said, to address the burden, what we could do together to address the burden that we can't do individually, and what should we be doing, what recommendations if we had fairy dust that we could sprinkle on a document and send it to the legislature and say this is what we would like to happen. And in doing that, we are very cognizant that that will cost money, and how much would that cost, so that the legislature can look at this with open eyes and make determinations. Next slide. We did not choose to call this a diabetes action plan. We already had a state action plan. We were in the middle of putting together our chronic disease plan for the state, which included diabetes. It's called Unbridled Health. So we called ours the Kentucky Diabetes Report, looking at it more as a think tank that got together and said, what do we have, and what do we recommend that it be done. Each agency had their own data content that they contributed and what their current programs were. A lot of these, as I said, had already been talking to each other because of the chronic disease plan that we were working on, as well as the state plan. We got recommendations from advocates. And then the lead agency took all of the reports that everybody brought in and kind of blended that all together for a document for everybody to look at and edit. Next slide. Multiple edits took place, as you can imagine, and reviews took place, and then we came up with recommendations and a plan for everyone to look at, and then finally drafted the final document that, as we say, was sent over the river, across the Kentucky River, to where the legislature meets yearly. So they could take a look, and then the next slide shows you an actual copy of the actual final document that I carried around with me for a while. We were very proud of it, and you can access that at the address is there for you to copy, and we would love for you to look at it. It's like any document; it's very fluid. And looking back now, we say, oh, we need to do this, we need to do that next time. So we have already started keeping notes of things that we want to do in our next rendition of this final report.
And I'm going to cover just a few highlights from the plan. Next slide, please. On the data side, we had lots and lots and lots of data, obviously, in that document. But one of the things that we hadn't had much experience with data-wise prior to the development of this document was the data from personnel. We had seen Medicaid's data, we'd seen a lot of other resources that were in the document, but the personnel data was relatively new to us, and so we really were very excited to see that. That was a very rich data source, and got very excited about all the different things that we could learn from that and could use to move forward with policy, etc. So that was a really nice experience from this process. In the section where we each got to describe our work, I just mentioned this just because it's just one of those things that you deal with in doing work like this, but you would think of all the list of things in this report, that would be the easy part. Well, we can talk about what we're doing, that'd be easy. Well, not really, because as was true in a lot of places in the country, our diabetes program was really undergoing a lot of transition. Our Medicaid program was in the middle of implementing managed care in the state, which that was, a huge ordeal, and so everything was kind of in flux at the time we're trying to talk about what it is we're doing. So even that was a little bit challenging, but we got through that and got to our recommendations. And in that, as Dr. White had highlighted, we had decided not to call this a plan. As Marty had mentioned too, really actionable items for the legislature was really, I think, the way it was worded early on. So we really called them recommendations, and we really didn't want to say we were writing a new plan because we had plans. So we were really going to make recommendations about let's work with those plans. I should also mention that 2020 was happening at that same time as well. And so we really had a chronic disease plan, a diabetes plan, 2020, and this thing all kind of happening at the same time. So we really had to think about that a lot. But the good thing about that was we also got to make those things align as we were working. So that was actually a good thing. And continuing, next slide, with some additional highlights. We also made recommendations about the diabetes prevention program, as Marty highlighted. We made recommendations regarding diabetes self-management education and supporting the availability and sustainability of that. We spoke specifically about some pilot projects with our Kentucky Employee Health Plan, both related to the diabetes prevention program as well as the diabetes self-management education. And we also, Dr. White is going to share a little bit about KHIE, but we wanted to write in some things about supporting the use of electronic medical records and our Kentucky Health Information Exchange.
Kentucky has been very lucky that we were very early in the game, began working with electronic medical records, and we have developed, we call it KHIE, K-H-I-E. KHIE is an electronic information exchange. It's been recognized nationally as a national leader, and with Health Information Exchange with KHIE, it is an opportunity for hospitals, for providers, for laboratories, for pharmacies to be able to place their data into a secure site where other providers that are a member of KHIE can go into, query a particular patient, and you would be able to find out what providers they've been to see, what hospitals they've been to see, what their labs were, what their x-rays were, what their hemoglobin A1C was. And so it's a tremendous data source as we try to manage a patient or try to look at patients, and as we are able to start, as more and more people participate, develop reports for statewide health information. So we certainly encourage that, and that was in our recommendation plan, and we're seeing those kinds of things happen. Next slide. One thing that we did want to do is the Office of Health Policy, which is in our cabinet, has hospitalization records and ER visits from all over the state. However, they are all de-identified, which is the arrangement and agreement on the front end. However, that makes it difficult for us to track a particular patient because we don't know if the 5 admissions to the hospital that month were the same patient for diabetes or was it 5 different people. We have a new director of the Office of Health Policy who just started a couple of months ago. We're working with her on several other projects, and so we are hoping to be able to see a way that can be done so we can do a better job at reporting trends going forward in our next report. The BRFIS data that we have in Kentucky, we've been also very lucky. We have a new BRFIS director who's been there probably a year and a half now, who has done a tremendous job in strengthening that program. She is over sampling in the African American community to be sure that our data source there is strong. We have started, and we're one of the first states to use cell phones on our BRFIS survey, so we are getting a completely different demographic of who's sitting around at home waiting for a landline to be answered versus somebody who's on a cell phone, which has given us some interesting information. And we also have piloted a project where prematuras will actually, in Spanish, talk with people and get their answers on a paper survey. So it is a BRFIS telephone survey, except it's done on paper. But that has given us a lot of information in our Hispanic population we would not have otherwise. And one of our recommendations was that we take out the opportunity, take advantage of the opportunity to do a health benefits exchange and expand Medicaid. And I'd like to think the governor read our report and decided to do that because of our recommendation, but I think he already had that in mind. So this spring, our governor did announce that in Kentucky, our health benefits exchange will be going live October 1, and then starting January 1, Medicaid will be expanded in Kentucky. Next slide.
Okay, so to talk a little bit about results, we did a report, submitted it in January, and so now where are we? Well, so far we have not had any direct commentary back from the legislature, but we know that our 2014 session is gearing up, and the reason the report was turned in at the timing it was, we hope, is that folks will be able to read it and discern it and decide, gee, I'd like to pick up recommendation A and get some legislation or movement going on that particular piece, and would have time to file that before the session and that sort of thing. So we're hoping that there'll be some really good news and some movement on some of our recommendations for the upcoming session. So we'll wait to see what happens with that. But in addition to what Dr. White's mentioned, we have made some progress. As I shared, we had made some recommendations that related to the diabetes prevention program. And since then, we have received a grant, a small grant from NACDD to further some of that work in the diabetes prevention arena. So we've been working really hard on that. And we are in ongoing discussions with our state employee health plan about a pilot DPP project for our state employees. It's looking like that's gonna move forward, so we're very excited about that. That was one of our recommendations. And they are still actively conversing with us about making DPP a covered benefit. They've certainly expressed interest in that. It's really a question of timing at this point and logistics, but they really are very interested, and we've had some really exciting conversations about that. And we also have some movement on a Medicaid DPP pilot as well, and that's in the early stages, but we are really hopeful that we might have some movement on that as well. So some really exciting things happening around DPP, and I think that the ability of us to sit with personnel in the room and talk about these things as we were putting this report together really helped propel that forward. Next steps, as Dr. White also mentioned, we've already started talking about our 2015 report. Next slide, please. We have met once about the new report and once to celebrate the old report. So we've actually met twice in kind of debriefing about the last one and thinking about what we want to do next. And so we're already moving forward on that. And we're looking again at our recommendations and how we align with all of these other plans that I mentioned earlier. That actually has come together rather nicely. Having all of those things together was sort of kind of a bit confusing for a while, but actually, as I mentioned, it really was helpful in being able to align those things as we were building them. So that was really helpful. We'll keep doing that as we go along. And then I will let Dr. White tell you about our lessons learned.
Next slide. This is not just another report. This is not something that collects dust on the shelf. This is a report. This is our think tank. This is our wish list. This is what we want the legislators to know about diabetes in the state of Kentucky. We did learn that assignment for the management, for project management, you need to have people that are at a level that is able to speak about someone who can speak with authority for their department. We were very lucky. We haven't mentioned Commissioner Joe Coyles, who is the Commissioner for Personnel. I wasn't here, but evidently he would come to the meetings and nobody really knew who he was. There was this really energetic young man, and we finally figured out he was the Commissioner for Personnel. And his level of energy is boundless, and he is very passionate about this. So gather the passionate people you can find. The other new thing that we have now for someone who can speak for authority with your agency is we have a new Director of Medicaid Services, Medical Director for Medicaid, Dr. John Langfeld, and he's an informatics geek. And it's okay to say that because that's what he refers to himself as, but he is going to help us just enormously compared to our last report with his ability to mine data out of the Medicaid system. So we will have a much richer data source there. And it is a time-consuming process. So writing this report, you do need to look at your own personal infrastructure. Do you have the infrastructure in your department, in your program, to write this? We were able to do that here in Kentucky, but people have asked us, did we hire someone to write it? No, we didn't. We did this all ourselves. So everybody has to decide what they can and can't produce. Next slide. So the term diabetes action plan to us was a little bit created a little bit of confusion, so that's why we called ours the Kentucky Diabetes Report. And we also, again, cannot begin to thank Marti enough for her help and the NACDD to help lead us through this project so that we could come out the other end with a document we were pleased with and hope to be even prouder of our next time around. Next slide. So I am an OBGYN physician. I don't know if this was like a 9-month gestation. I think for Teresa it was longer than that. Multiple agencies working together, addressing our common enemy that I would say we are trying to fight. It was worthwhile. It really did help us to focus more, and I think the relationship that we built with the Kentucky Employee Health Plan is going to be extremely valuable going. We were very close to getting DPP as a covered service this year, but the time just didn't allow it. But there is a definite desire by that program to include DPP. I think we will, at next year open enrollment, October 1 of 2014, I'm predicting we will have that. Next slide. So again, there's the address if you would like to get a copy of our report, and there is contact information for Teresa and I, and we are more than happy to answer any requests that you might have. And that's all our presentation.
Great. Thank you to Marty, Connie, and Teresa. We have about 10 minutes for some questions. The first question is for Connie and Teresa. What is Kentucky doing to ensure that gestational diabetes screening is being done for several populations, including Medicaid, state employees, and the general population?
We don't have any specific interventions in Kentucky for what obstetricians or providers need to screen for. Being an ACOG member, American College of OBGYN, and an officer in ACOG, I certainly would hope that people are following ACOG guidelines, but that's not an area that we have addressed legislatively. We certainly do have data in our report about gestational diabetes, the amount of money, more hospitalizations, more cesarean sections, and that's probably, I think, something going forward we will begin addressing, but at this point we don't have anything.
And I would add to that, if I'm remembering this correctly, I believe that we had conversations about whether or not to include data about gestational diabetes, I believe, in that original report, because I'm not sure the original legislation actually asked for it, but we thought it was important. We did not, as Dr. White mentioned, write in any specific recommendations about that.
Okay, and our next question is for all the presenters. It is who should be included in the report group, such as advocates, consumers, legislators?
This is Connie from Kentucky. One thing that Teresa and I spoke about when I first got here and the report was being written, I thought it was good that, and this is my opinion as a physician, when I read this report, no one could say that we had been influenced by any outside entities. This was all data from state government folks. Now, having said that, going forward, I think it would be important for us to bring advocates in. But as a physician, when you read a document in a medical journal and then you read the list of financial attachments that people have, it kind of, for me, jades how I read or look at it. And this first report for us, I felt was very pure. There could be no misinterpretation of what our intent was, but I think it will be a better document going forward as you bring in other advocates.
And,
yeah, I would tend to agree with that. This is Marty. I think that for sure states should absolutely include the program folks in the state health department that are implementing diabetes interventions. They are funded by CDC to do so. I think it's really important to have your data folks there to help you synthesize the data that comes from all of the organizations. And then as the process unfolds, be prepared to bring people in as you need them.
And I would add, this is Teresa, I think that we had some of those conversations early on. The legislation told us specifically who we had to have at the table, but we talked about, should there be other people at the table. And we kind of decided that we had just written diabetes plans and we're in the middle of writing chronic disease plans, so we had folks out there that had contributed a lot of input about what they thought should happen about diabetes, and that's why our recommendations reference those plans. So we didn't sit up here in our little ivory tower and decide this is what ought to happen. I mean, we felt like by referencing those plans and saying support those plans and support those recommendations, those were, in addition to being the things that we were thinking about as government agencies, we also knew we had a lot of input from advocates and partners saying about what they thought was important. And so that was a way of also including people who weren't necessarily sitting there at the table, but their input was heard.
Great. Well, before we close today, I would like to remind all participants that the webinar audio and the slides will be posted on the CSU Knowledge Center, and as an attendee, you will get notice of the link for the audio and slides. One more reminder is that there's still time to register for the 2013 Chronic Disease Policy Academy and the CSG National Conference in Kansas City, Missouri from September 18th through the 22nd. You can register at csg.org. The Policy Academy will focus on chronic diseases, their burden to society, and evidence-based strategies for prevention, identification, and treatment. State policy strategies will be presented to meet the dual goals of improving health outcomes and reducing healthcare spending. And health programming at the conference will include a session on state approaches to obesity reduction. Speakers will explore elements of the policymaking process that led to obesity programs in various states. The session will focus on educational reforms, transportation developments, land use changes, and food industry initiatives. Thank you again for joining us today, and thank you to our speakers. Keep watching the CSG website for scheduling of more health webinars.